time. So I want to welcome everybody today to this panel looking at cancer versus COVID and has the pandemic upended cancer care. And a recent a report out by the BBC today has indicated that there are reports that it has affected it, looking at a drop by about a quarter of people achieving urgent catch-ups between April and September, and the numbers starting cancer treatment are also down by a fifth. But NHS bosses have reassured us that they've got back to pre-pandemic levels by the end of September. So we want to maybe hash through those claims and see if it's true. But what's key to this is, as we enter a second wave, is that we learn from what happened in the first wave, and that we have action points and plans and mitigations going forward. So I'm really pleased to have such amazing guests today on. So we have Deborah James, who's known on Twitter as Bowel Babe. She's an author and presenter, including the Channel 5 programme You, Me and the Big C. We have Dr. Stephanie Cuckoo, Senior Consultant, Hardian Health Advisor and Consultant in Clinical AI at the World Health Organization. Linda Thomas, who's the Chief Executive of Macmillan Cancer Support, who recently published a report, Cancer Support, published a report on Forgotten MC impact of COVID-19 on cancer care. Dr. Navan Ramachandran, a radiology consultant at the University College London Hospital's NHS Foundation Trust and a co-founder of Open Cancer. Professor Pat Price, oncologist and founder of the Catch Up with Cancer campaign, and finally Dr. Matt Williams, consultant clinical oncologist and lead in computational oncology group at Imperial College London. So to allow us to get to everybody and have a chance to speak, we're going to run through some questions. I'll go to two of you to speak, and then we'll have open answers. I'm afraid we don't have time for Q&A from the audience, but if you do want to type in a question, if we do have time, I will look through those. So the first question I'm going to ask really is to deal with this issue as to whether how has the management of patients with cancer been affected by the COVID treatment in terms of the treatment and impact on capacity delays and overall experience? So I'd like to go to Linda Thomas. Is Linda in? We might have to switch to Matt. Matt, have you got...
Yep. Can you hear me?
Yes.
Oh, good, it works. All right. So really briefly, there's clearly been huge impacts, and it's worth just differentiating why some of those have happened. So the first thing is that during the first wave, there was clearly a problem with transmission of COVID inside hospitals, and therefore there's a huge amount more cleaning and isolation of patients as they go through hospital, and that therefore has a massive effect on capacity. So our capacity is down, and that's an important thing. The second thing is that you have to remember that most adult oncology is downstream of other services. So it's downstream of primary care, radiology and surgery. And certainly during the first wave, I think quite rightly, the amount of surgery decreased very substantially because there are very clearly large risks associated with giving general anaesthetics and doing big operations in people who might be COVID positive. And then the third thing is that fewer people went to see their GP. So some of that has now recovered. Our department still doesn't have the capacity to treat as many people as quickly as we did this time last year. But actually, the thing that's constraining our treatment numbers at the moment is the fact that we're still not getting the referrals. So at the moment, the thing that's driving that change is patients being worried or not being able to access their GP, and then not being able to access those downstream tests. And so particularly for the common adult cancers, particularly for bowel and lung cancer, there's often a heavy dependency on endoscopy, and endoscopy is a significantly risky procedure in people who are COVID positive. So because you now have to COVID screen everyone, and you have to ventilate an endoscopy suite between each patient, your endoscopy capacity has gone down considerably. And so our ability to diagnose some of those common cancers has substantially reduced because we no longer have the same amount of capacity as we did do.
Okay, thank you, Matt. It was nice. Linda, who was due to just respond first on this question, hasn't been able to attend just yet. So would anybody like to jump in and comment on the evidence that cancer has been impacted and the types of treatments that are available then?
Shall I comment here?
Yes,
look after the Catch Up with Cancer campaign, and our charity takes surveys from what's going on the ground. So we kind of do know what's going on. And I absolutely reinforce everything Matt said, because remember, we had guidelines out in March about how to delay and avoid treatment and change treatment. So the whole of cancer treatment and the whole of the cancer pathway was disrupted. I think the problem for us now is the frontline staff, amazing, working fantastically, and all these challenges, as Matt has said, to actually get patients through and done is there. But our layered on top of that is we need a response in terms of actually getting services, the whole of the pathway up and running, which is an organisation thing that needs doing. And I think we'd be concerned that this wasn't done fast enough. Because really we've been shouting about it since April, since the big first wave went over, and now we find ourselves we're coming to the second wave and we've actually not got it all together. So this is compounding problem. In other countries, I think we knew the waves coming through from Wuhan and Italy. We knew what to do, and I think probably we were a little bit slow in then getting things back together again. There was one hospital in New York, the main hospital, they had 1,000 patients on ITU at the height, it was carnage in New York. They got their cancer services up and running within 3 weeks. So it's about the will. And I think our thinking is the government should put as much energy into getting the cancer services up and running again as they do in the COVID. Data out in the BMJ last week showing that for every 4 weeks delay in treatment, so that's 4 weeks delay in diagnosis as well, is actually up to 6 to 10% reduction in survival. People think we're probably 10, 15 years behind in survival now. It's been absolutely decimated. So there are big problems, and cancer doesn't wait. We've got to have some urgency. Again, another study, 60,000 lost life years. It's a massive problem. And now, how do we deal with the backlog? Jeremy Hunt has suggested we need to go at 120% of the rate once we get up to normal for 2 years. You can't expect the NHS frontline staff to just be going 20% faster. It isn't going to happen. That means investment. We've got the comprehensive spending review. It needs investment. We've got to be focused as much on cancer as we are COVID and the economy. Otherwise, people are going to die.
Yeah, some good take-home points there. Certainly one struck the chord is that cancer doesn't wait. I think that will strike a chord with quite a number of people. I just want to welcome Linda. Also, can I just ask that we mute our microphones when we're not speaking? That will just help with the quality of sound. Linda, we're just discussing the evidence on how has the management of patients with cancer been affected by the COVID crisis, and Matt and Pat have just talked on that. And I know Macmillan have produced a report looking at the evidence and the actual areas where this has been impacted. So I'm just wondering whether you'd like to have a brief comment on that.
Yes, thanks very much, Alison. So we produced a report which was published a couple of weeks ago called The Forgotten Sea, which showed that there were 50,000 missed diagnoses in the time between when the pandemic started and now. We estimate that the 33,000 people have not yet started treatment that should have started treatment. Delighted to say that the latest NHS waiting times figures came out this morning for September, and actually we are now back to pre-pandemic levels, but that does show that it's taken between April and September for us to get back to that point. We estimated in our report that it could take 20 months to clear the backlog if we didn't get above 100% of pre-pandemic levels. So as you can see, there's a very long way to go before we can confidently say that everybody is in the system and being treated in the way that they were pre-pandemic.
Thank you for that. So I did say at the introduction that it was stated that we were back at pre-pandemic levels. So that data was quite useful to confirm. Would anybody else like to just comment on this section? Pat's put a hand up. Go on, Pat.
I just think the data out today shows the 62-day wait is about 70%. It's nearly up to. But that is because the patients aren't coming through frontline in the departments. As Matt says, yes, we can treat the patients because they're not coming through. So I think we mustn't be seduced to thinking because the 62-day waits are not too bad. Yes, that means the frontline staff are working really hard. It doesn't mean we're getting rid of the backlog. So, and the problem is, what do we do when the backlog does come through, and how are we going to deal with it at the moment? I don't know if Matt has something to say about that.
Vital points about that.
I think there's a really important distinction when we think about reducing services during COVID. So one of the reasons for reducing services is because The health service didn't have the resources to cope, so we had lots of our CNSs redeployed, our junior doctors redeployed, so our capacity goes down. And that's obviously something we need to try and avoid during the second wave where possible. The other reason, though, is that for certain groups of patients, and particularly certain procedures, it's not safe for those patients to undergo those procedures. So if you're in the middle of a COVID pandemic, it is not a good idea for that patient to have a large surgical procedure if you don't have really good COVID screening measures. And it is important to distinguish between those two, because the first one can be at least partially solved by making sure that you don't end up having to redistribute staff. But the second one actually is based around COVID control. And if you don't get good control of COVID in the community, it's going to be very difficult to provide safe services, no matter how many staff are around. And it's worth distinguishing between those. The other thing just going forward is pre-COVID, clinical oncology wise, we're about 20% short on workforce of where we need to be. So the idea that you can simply step up your workload by 20% above pre-COVID levels, it is really not feasible. There's a really nice comment, I think, from the head of the NHS Confederation, saying that COVID seeped through society like dye, exposing all the cracks. And I think it's a really good analogy, because what it's really shown us is it's shown us where we're really short on capacity. And COVID kind of shows that up and shows you where we've had gaps in pre-COVID service.
Have we got another comment on this? How has COVID impacted? Or can we move on? Because I'm quite interested. A number of comments been made about the fact that patients haven't been coming forward, and this is creating a backlog, and how we manage with that, and how I think the point of reduced staff is very, very important point. So then we've got this, we want 120%, we're dealing with 80% staffing levels. So how does that go together? Deborah, the next sort of focus of the discussion is really looking at impacts on patient outcomes. And I have a couple of questions that, from your point of view, you give the patient perspective, and I'd really be interested in your general thoughts on this issue.
Yeah, so obviously I come to the table as a journalist and as a patient. From a patient perspective, I think the number one thing that we haven't even mentioned yet is the impact on mental health. So we know in the big picture, COVID is impacting on mental health, but then the layer of that on top of cancer is just quite an eye-opener. To undergo chemotherapy for the first time on your own, to undergo these operations on your own, that is putting people off, and secondly, it's so complex. It's really heartbreaking to see actually on the ward when I'm having treatment every week, these people coming in for their first time, and nurses and staff are brilliant, but it's, you know, you can't take it away. It's cancer in normal times is hard enough. For me as a campaigner, I feel very strongly that cancer is obviously the forgotten C, as Linda well pointed out. I feel that we pride ourselves as an NHS on not putting a price on a life, and yet it feels very much that actually as a cancer patient we were rated, we were graded. I, as a metastatic cancer patient, was at the bottom of the list. I was very lucky that I was in one of the protected cancer hubs, and therefore I continued with vital treatment that keeps me alive. I know the personal stories, these numbers of people's, their families with kids, and the impact that has on their life is immense. It's the anecdotal things that we don't see in those figures. It's the number of stories of people saying, oh, but, you know, I don't want to bother my GP. I think the thing that we forget, and I'm not saying the GPs are the gatekeepers, but essentially they are, we assume that actually people are all digital natives. We assume that they can access care. We know that we have reports. I was investigating lots of downgrading of referrals. So I think to put the blame on the public when even in good times, we know it's challenging to get them to come forward. I think we have to look at how we do that better to reassure them that actually we're there to help, rather than they're not going to be overburdening a system.
Can I just add something? I think from what both Matt said about the cracks and what Deborah said, I think one of the things that we have to also consider here is inequalities in cancer care existed before COVID. And we have to be very aware and really think about how we are going to make sure that they don't explode. A couple of things. The International Cancer Benchmarking Study from years ago showed that the reason that the UK were behind a lot of other high-income countries in cancer outcomes was this presentation to diagnosis time. This comes back to primary care. A follow-on study in the UK published in the BMJ showed that the cancer outcomes were directly linked to the willingness of GPs to investigate symptoms when patients come in. That woman that keeps coming in with, oh, a bit of pain, she's got ovarian cancer, but they didn't listen. And we also know that that geographic location also factored into that. So now with COVID, we've got this presentation to diagnosis is one thing, but now we've got the delay in symptoms to presentation because there is no access to your GP, because it's chaos. Everyone's just not, everyone's not feeling great. So of course it's harder to spot symptoms, and it's harder to access your GP, let alone finally getting your GP to investigate symptoms before you're referred for your 2-week wait and before you're diagnosed. And so inequalities, I think, is something that nobody's talking about in cancer care. And I saw it. I worked in the best cancer hospitals in England, and I saw how easy it was to have unequal care, how the surgical waiting lists were so stretched that we would change treatment plans, and it would so much will depend on these non-quantitative measures of predicting who was higher risk. As Deborah said, I'm prioritized, how you prioritize patients. The other thing to say is, and I don't know if Matt would agree with this, when I looked at the Imperial modeling study, and this is back in June, I think I looked at it, I haven't looked at it since, I seem to have seen, and I may be wrong, Matt, that the hormone-driven cancers in women seem to have worse predictions for the delay. So, of course, being someone who did women's cancers and still being, involved in women's cancers, I don't know if I'm being sensitive here, but are women's cancers going to have worse delays? A couple of my colleagues at UCL have discussed the fact that we're doing things like saying stage 1 uterine cancers are low risk, they've got good mortality, so we can delay them. But we've seen, and I think Matt and I published a study on outcomes in endometrial cancer years ago, we've seen that stage 1 cancers with delayed treatment can represent with relapse within a year. We know that presenting with a stage 1 cancer at time X and 3 months down the line, it might not be a stage 1, or it could be a stage 1 with a node found on lymph node dissection. So I think there's so much that I think the leadership and governance around the way we're looking at cancer ahead, and the media is covering it, but I'm not sure.
Jump in. I just have to jump in there, and so thank you so much for highlighting the issue about inequalities in care and cancer outcomes with that. I think that doesn't get discussed enough, and it does link to one of the questions that I asked is, were there different types of patients or different types of cancers that have been impacted more severely than the others? And I can see Linda's nodding, but Pat, I had you down originally to sort of lead on this section, so I don't know if you want anything to add, and then if we have time I'll nick to Linda and to Matt, and then Navin, I promise you'll get your moment. Pat.
Yes, no, and as Deborah said, we were all issued with the priority list at the beginning of COVID, and that's what it was. And this was the patients you treat first, and then if you go down in your priority when you get them. And as Deborah said, secondary cancer at the bottom. So we have an inequality in patients, inequality in tumour types as well. So that is there, and also the recovery. I think we should have had smarter solutions to that, because obviously you can do a lot of substitute treatments. People who can't have the surgery now should be pushed towards some of the radiotherapy where it's an option, that type of thing. So there are solutions to that as well. But also we must remember, as I said before, we need to act, because the longer we leave it for some, the worse it can get. And people are hidden in the backlog. For instance, we've been told in prostate cancers, treating them, give them hormones and delay. So some of those are still in the system waiting for their definitive surgery or radiotherapy. So it's different tumour types, partly related on how fast they grow. And then some in terms of lung cancer, the lung cancer charity group put out that 75% in reduction. They thought a third of their lung cancers had died during those 6 months. So it does affect it. And I know on the ground we're coming seeing patients are presenting. We're seeing tumours we haven't seen before. They're so late presenting. So it has a massive impact all around. And as Deborah said, it's an individual. You don't want to be considered at the bottom of the list, do you, Deborah?
No, that's very good. Deborah, you're on mute.
To also add the message that whilst it wasn't publicly made aware that screening was halted during the first lockdown, we know that there wasn't a NHS trust in the country that continued with it. I'm currently trying to find out if it's going on at the moment, so any information would be great. But I think actually that message that actually cancer can wait was very clearly sent out to pretty much everybody in the country, and I think that is a message that we need to rectify moving forward. And I know that there's a question to me, what do we need to do to make sure we don't go back to treating cancer as if it's the only issue as if it's the only issue for their patient. And you're right, it is getting those gateways open, because obviously whatever mechanism we were using before was not working, hence why we're behind Europe in terms of where we're placed at the moment in terms of our outcomes.
So you're nodding a lot. Do you want to comment?
So I just want to agree. I mean, I agree with Pat really, and I think what we've seen is breast and prostate have been more delayed than other cancers. Lung has been really badly hit because the same symptoms of lung cancer are the symptoms of COVID. So there's been a huge confusion around that. But I also wanted to pick up on Stephanie's really valid points around inequality as well. We know that for some people, it can take 5 or 6 appointments at a GP in good times for them to be able to get themselves referred through, because actually vague symptoms are really hard. Unless you use the right language and unless you use all of the right sort of symptom trackers and things like that, then people may not pick them up. But try doing that over a digital call or a telephone call, and you can't, the GPs have got no access to all those visual markers that they might see from, they might look at someone and say, that person looks like they've lost weight or they look really ill. None of that is happening. So I think people who can't access services digitally are going to be disproportionately affected by this, and we will start to see that happening, I am sure. And we're going to unfortunately see many more people dying as a result of them having either sat at home and thought this is not for me, or tried to get through the system and been unable to get through the system. So it's really true what you said, Stephanie.
Thank you for that. Navin or Matt, do you want to add a final comment on this section before I move us on to, well, okay, we've dealt with it now, let's deal with what we can do about it and make sure we don't make these same mistakes going forward. Navin, would you like to say something? Be very quiet.
Yeah, thank you. I think this is a very tricky topic, and the panel here is very focused on cancer, and I am as well. And I think we've seen this in multiple other specialties as well. So if you look at cardiology and the amount of people who turned up with bad coronary events because they kept holding off, I think that's a theme that goes throughout the whole of medicine. And anything that can cause death was much more likely to cause it during this time. So the question is, are there things that are very cancer that we need to tackle, or are there things that we need to support patients around, and also the healthcare systems and how they adjust to something like this? So I think we will touch on a bit of that in the next section, and I'll stop there.
I think that's a very good point. You know, yes, to see we can let other issues within this response and, you know, outside of cancer treatment. Matt, do you, Stephanie's referred to some of the work that you've been doing together or have done together. Do you want to add a final comment?
No, but I think just to pick up the fact that inequalities are important, but they're often quite difficult to wash out of that headline data. Very big numbers, and it's often difficult to pick up evidence for inequalities from that. And then just to pick up, in terms of Navin's point, I'd agree that healthcare's been affected globally. Oncology is often quite different though, because it's often they've often got quite long pathways with multiple events. So if your endoscopy capacity goes down by 20% and your imaging capacity goes down by 20% and something else goes down, you can end up kind of getting multiple bottlenecks on your cancer pathways that have this kind of multiplicative effect. Whereas cardiology, from when I did my SHO job a long time ago, I mean, it's pretty simple. You just stick a cath in something.
Okay, now, okay, we'll move on from that. Right, so I have to admit that I thought I'd be very calm in dealing with this panel, but we've all known or experienced issues with cancer ourselves and lost families, and I'm finding this incredibly emotional, I will be honest with you, to listen to. And I hope to come back to you, Deborah, and to make sure, because I want you to address that. The top question that was asked to you in that block was, how have you dealt with the added burden of having to deal with the pandemic personally? So before I close for the summary, I will come back to you for that question. But moving forward, I want us to think about, well, lessons learned then. We've addressed that there has been a problem. We've highlighted some of the ways and areas where there have been problems, hinted to how we could do some actions to deal with it, and where claims have been made and requests have been made for 120% staff working away at it, and that to deal with the backlog isn't going to fix it. So I would like us to think about the lessons learned. So Navin, I'm going to come back to you first to deal with this question. So it said, do we have the modelling data that we have relating to second and third waves of the and expected impact of that as well? So do we have forward-looking data, and also think about the practical proposals that we can address this issue for more waves of this particular pandemic, but of course pandemics that may well occur in the future. And then I'll come to you, Stephanie.
The modelling data is not my forte, so I'll leave that to the rest. Concentrate on the practical aspects. So the first thing, so I made a list of things that I was thinking about. First thing Deborah touched on right at the start, it's probably the psychological aspect which gets forgotten. So there's the worry about the cancer itself, and we had, just from personal experience, lots of people coming in with one pathology who on their scan at the bottom of it get a cancer diagnosis. So they come in maybe with renal colic, and during that time you get both that diagnosis, worry about being in hospital with COVID all around you, and a cancer diagnosis, and then that cancer diagnosis almost gets put to the side. So there's that to deal with. There's also the isolation, so they end up going home without the support network they had before, and money worry. So loads of these people were furloughed, maybe lost their jobs, and all of these things mount up together. And these psychological worries don't just affect the patients, they also affect the staff, especially as they start burning out. If they're going to be working 120%, I think you can see a lot of that, and I think we've got to be ready for that. What things did we do well? So from my experience, I work at UCLH, Royal Free for renal cancer, and Westmoreland Street for the other urological cancers. And what I saw done really well was working across a network. So we have these cancer networks set up. There are processes in place. So when they work well together, it does well. So what we had were hot sites that treated COVID, and you had cold sites that were specialized in cancer and other kinds of surgery. And I think the main problem was with this kind of system is, how big is your outbreak? If your outbreak is big, you've lost everything. But I think you have to dynamically manage that demand and see what you can make a cold site and how much you can maximize that. And obviously you use any private sector hospitals you can to do that too. The biggest problem with something like this is the flow of information between sites. So that's one of my pet subjects, is information flow and semantic modeling. So it all sounds great. They'll go from here to here and they get treatment here. This is a part of a standard cancer pathway. You move from one site to a tertiary site, maybe a quaternary site, and the records don't necessarily follow you. Or if they do, you end up with a PDF of 100 pages that you'll never be able to see the whole thing of. So I think here's a time, it's a big task, but we've got to think about this interoperability. It's a buzzword, and it's actually much harder than we think. But I think if you truly want information to work across a network, we need something like that.
That's a very good point. Stephanie, I'd like to come to you.
I'm just going to follow on from what Navin, and I think because I work in digital now, and what I do is evaluate digital health and AI to see what is actually going to make a difference to patient care. I think that what is important is that information flow. The NHS wasn't prepared to do digital well. It can do digital well. It will do digital well in the future. And no other specialty, of course I'm biased, is more in need of a very efficient digital coordination of care. It's got to be holistic. At the time I was leaving the NHS in 2018, the shortages in the healthcare workforce were starting to affect all of us. So the cancer specialist nurses, for me, they're the most important people in cancer care because they cover everything. They join the dots, they help with the holistic, they help with the mental health, they support the patients. And there are less and less of them. And they were able, they didn't have many means to communicate with patients and specialties. Digital could help them. We cannot underestimate the NHS workforce. GPs and doctors are aware that cancer outcomes are going to suffer. Everyone is aware, and nobody wants to do less than the best for patients. However, everything starts with the leadership and governance, and I think that we've seen from the pandemic as a whole has been blown out into the open. It has to change. There is no going back. Those cracks have to be filled at a very, very, very high level. And so I think that's it. I think it's, the future is really kind of getting digital to work well, supporting the workforce better, and really doing everything to make sure the cancer care for patients is more holistic and connected. And if it was, then we would have been stronger in dealing with this pandemic.
Okay, I think some really vital points have been brought up there, and looking at the information flow, but that does relate to me in my head of the disconnect between social care, public health and NHS and so on and so forth, which causes a problem, doesn't make life easy, and mental health, a slight separation of that. I can have a rant about that. But Linda, you put your hand up, so I'm interested in your comment.
I think just a few practical considerations as we enter the second wave, and particularly thinking about what's happening all around the country rather than just thinking what's happened in London. The first thing is we've got to protect cancer staff during this second wave. People shouldn't be redeployed. Stephanie's absolutely right. Clinical nurse specialists, the glue that holds everything together. Too many people redeployed during the first wave onto critical care, then had to come back and now doing their day job and having to do more of that. So we've begged government and said we cannot redeploy staff again next time because actually they're so critical. I think there's also something around asymptomatic testing of staff to make sure that we have as many people working in the NHS as can possibly be there. And then also just thinking about the rest of the UK, I think the clean COVID sites worked really well in London, and the use of private medicine worked really well. Hospitals worked really well in London. It didn't work so well elsewhere. And of course, there's an awful lot of people who don't live in London or in the major sites. And then finally, just to say, psychological support for staff has been invaluable. I know lots has been put in place for that, but I think the more that we can do to support staff during this period is absolutely vital as well.
Pat, now I'm going to come to you and then to Pat, and then I would like a final word from Deborah. Oh, and Matt, if you've gone, I've not come to you as well, so if you have something burning to say, obviously please do say.
The two things, I just want to make a brief distinction. I think we've touched on it before. The digital aspect is very useful for staff working, but I think we've got to be careful that if we push it out to the patients, you're going to get that inequality, and some people just aren't going to be able to handle it. The digital, I think, is very useful in staff-wise, just in terms of isolations. There's two things: keeping people apart. Can you start doing some meetings apart? So NDT meetings where you discuss cases, you do them remotely, don't spread the virus. For staff, that's great for infection risk. It may not be great because you'll also be expected to work when you're isolating at home. And if you've got 3 kids to look after at home, it doesn't always work so well. So I think we have to be very wary of work-life balance and what happens around that time. I won't go on anymore because I think Pat wants to say something.
That's true, and you've also been very lucky that you haven't had my dog's leap up throughout this talk. Pat, you said you're just.
Yes, and I think Linda support absolutely everything you've said, but I think we'd go further and say we've got to find some solutions going forward now that actually solve us and build back better, as they say, get a better service. And a lot of that in all our business area, it's IT basically, isn't it? And we have put forward some solutions, particularly like radiotherapy is a technology-based subject. There are massive amounts you can do. We did a survey at the start, 25% of the staff didn't have enough IT to go home, a remote plan. ridiculous. And yet we've got solutions that have been sitting there waiting for NHS England to fund for years. And I think the government and the powers that be need to get on with it. And also data will help us forward. The government don't know at the moment how big the backlog is. They have to wait for Macmillan to do some research to tell them. And yet for the radiotherapy, we can have our data sets that are actually sitting with Public Health England and have been all this time, not yet freely available, will tell us what's going on. We need to know what's going on so we can help build for the future. And we have to be thinking much more the future. Take all these things we've learned now and leap ahead and make it a better service, not just to catch up, but for the future as well.
I think very good points. Deborah, this first question that was sent to you, that says, I just feel like the patient voice needs to be the final say before I come to everybody for a final take-home point. And the question that sort of stood out for me was, how have you dealt with the added burdens of having to deal with the pandemic personally? If you don't mind saying, obviously, if you want to speak on a general level, that's fine.
Yeah, I think for me it's exercise, but I get that I'm in a interesting position where I run a marathon during chemo because I'm just a bit weird like that. But for me, actually, exercise has been a saviour. I think it is very challenging. I did 3 weeks of radiotherapy in the middle of the first lockdown, and I've got a few more coming up. And I think doing it alone is very hard. For me, it's made me want to shout even louder, to continue to write, to continue to do something so we can change it for the future. So I think it's putting that kind of frustration into something good. I just want to pick up, I think it was what Pat was saying, or about, it is about the future. The thing as a patient that always gives me hope is the idea of hope and options. I'm alive because of research. I'm kept alive on drugs that have only just been approved and still dragging its heels a little bit. And I think the fact that actually research was halted is still not back up to the levels it needs to be scares me for my own kids. It scares me for all the children, actually. And being an ex-deputy head teacher, I think that's what we need to keep our eye on, is like making sure that we, like Pat said, leap ahead and, you know, make massive strides in it.
Thank you for that take-home point. So in the last 2 minutes or so of the session, I'd just like sort of everybody to have a quick sentence or two that you want people to go away and think about. So Matt, I'm going to come to you first because we haven't sort of heard from you for a little bit. So key take-home point, Matt.
COVID hasn't caused anything new. Oh, yeah. COVID hasn't caused anything new. It's just shown us what was already there, but in much more stark relief. Okay, we've always been pushed on CNSs. It's only when you add COVID that those shortages become really.
Good point. Linda?
I think for me, I want to just support what Deborah said, actually. I think behind all these statistics are real people. And at the end of the day, everybody deserves as much chance to live for as long as they can in as good health as they possibly can get.
Thank you. Navin. Oh, you're on mute, Navin.
I think there's not much to say following that. I think we can talk a lot about tech, we can talk about guidelines, but
I'm a data scientist. I'm really struggling with me and not to pick that point up and run with it. Stephanie. Oh, on mute, Stephanie. We're doing so well.
Sorry, I have nothing else to say. I'm reflecting on Deborah's point, and it reminds me of my time in the NHS. I think we should get Pat and Deborah in a room with Matt Hancock and lock the door and not let him out until
I'm tired.
until they're done. But yeah, I mean, I think there's all the points to be made.
And no, all I would say is what I've seen, this needs real leadership. All I've seen since last April is people burying their heads in the sand, pretending it's all right. I know this data supports this. Stop doing that. It's not all right. It's a mess. We need to get on with it. There's patients' lives at risk, and the faster we get on with it, the better. And it should be given as much energy as focus as COVID and the economy. These patients deserve better, and it's not okay.
Thank you. And that sadly takes us to end of session. And thank you so much for everything that you put in. There's a lot of food for thoughts and some such enormous important issues raised throughout in 40 minutes. I really, really appreciate it and all of your time. So thank you.
Bye.
Bye-bye, everyone.
Thanks, Tom. Bye.
Thanks.